And so with tonight, it's probably going to be a little bit shorter than what the other two webinars were, regarding the heart blocks and symptomatic bradycardia and the tachycardia rhythms, because with cardiac arrest rhythms, there's obviously a very small number of rhythms that we have to look at. But more importantly, the overall treatments don't differ all that much. There's certainly some differences in the treatment between the pair of cardiac rhythms, or the two different groups, I should say, of cardiac arrest rhythms, but there's not a tremendous difference overall. So tonight might actually be a little bit quicker, not intentionally, but just because there's not as much material to cover as there has been in the past. But by all means, just like other live webinars that we've done, feel free to jump in the QA section or the chat section and ask any questions that you have, and I'll try to keep an eye on it as we're progressing along here. So let me get rolling. So we're going to start off with ventricular arrhythmias. And it's 2 weeks ago when we did tachycardic rhythms, we saw ventricular tachycardia. We saw VTAC, but we focused on VTAC with a pulse. Okay. So just a real quick review. Remember that if you're on an exam, or if you're on a hands-on exam and you are getting EKG rhythms slid across the table to you, or you're sitting there watching a cardiac monitor and an instructor has a rhythm generator and he or she is changing rhythms and you're interpreting them on the screen as they go by. Or if you see this happen on a patient, the very first thing that we should think of is, does it have a pulse? Okay. Because remember, ventricular tachycardia can either be pulseless, which we're going to talk about tonight, or it can have a pulse. And that is crucial in identifying right off the bat, because it's going to dramatically decide which route I head. Am I putting this patient in my tachycardia bucket and I'm doing my stable or unstable differentiation of 150 milligrams of amiodarone over 10 minutes, or synchronized cardioversion? Or am I putting this patient in my cardiac arrest bucket and we need to immediately start CPR and immediately defibrillate the patient as soon as possible? Okay, which we're going to elaborate more on that tonight. So the very first thing when you see VTAC and you recognize VTAC is, does it have a pulse, right? That's the very first thing we should be asking ourselves, or the moderator, or actually putting our hands on the patient if we're in the back of an ambulance or if we're in a clinical setting and this happens. Let's actually figure out, does this have a pulse or not? Okay. So as a quick review from last week, remember, ventricular tachycardia is a wide complex tachycardia. And what I mean by wide complex is, I mean the QRS complexes are wider than 3 small boxes, or 0.12 seconds. Okay. And I would really be measuring about there to there. Okay. So I'm about 4 boxes. So about 0.16 seconds is how wide my QRS complexes are. So anytime I see a wide QRS complex, I need to think it's a ventricular rhythm or a ventricular beat, right? Whether I'm talking about a PVC or I'm talking about an actual VTAC that I'm seeing on the monitor in front of me. So wide QRS complex, I should think this is a ventricular rhythm. Whether it's a ventricular beat or not depends on what the rhythm actually looks like. But in this case, this is clearly VTAC. Every QRS complex that I'm looking at here is wide complex, meaning that it's greater than that 0.12 seconds. And it is also regular, meaning that all of my complexes are equally distanced from one another. Okay, if we were to really stop and measure all of those, they would all have the same exact measurement. So that means it's regular. Doesn't mean it's normal to be in that, but it means it's a regular rhythm. All of my QRS complexes are evenly spaced from one another. It's wide. And then the last piece of that puzzle is, of course, the tachycardia part, right? So down here, you see on the slide, we have greater than 101 beats per minute. So by definition, we know that is tachycardia. Now, it's not common to see VTAC at slow rates like 110, 120, 130. but you can. Um, but generally, when we talk about VTAC, we're talking about rates greater than 150, 160 beats per minute. Now, in the cardiac arrest scenario, I don't really care about the rate necessarily. I care more so about, does the patient have a pulse and what does the rhythm look like of what they're in, right? Because I'm not really aiming to slow down a rhythm at that point. I'm aiming to change the rhythm entirely to get them into a more sustainable rhythm overall. So ventricular tachycardia, just a quick recap, it's wide QRS complex, meaning it's greater or wider than 3 small boxes, so greater than 0.12 seconds or more. And it's regularly occurring, meaning all of my QRS complexes are evenly spaced from one another, and it is tachycardic. Okay. Greater than 100 beats per minute, but generally we're going to be talking about greater than 150 or 160 beats per minute with VTAC. Okay. So moving on, these are a few different ways that VTAC can appear. It can be primarily negatively deflected QRS complexes like we see on the screen here. The QRS complexes can be all positively deflected. It doesn't really matter which way they're heading. Sometimes we see them heading in different directions. We call those multifocal. If it's PVCs, we call them multifocal PVCs if they're headed in different ways. But generally with VTAC, where all of the complexes are going to be going in the same direction, either positively deflected, meaning up, or negatively deflected, meaning down. So don't let the overall um, uh, minor differences in the rhythm confuse you. Don't let a different or a funky looking VTAC rhythm confuse you. At the end of the day, remember to apply your rules, just like we've been doing all along in this EKG series. Is it wide? Is it regular? Is it fast? If you answer all those questions, yes, it is VTAC, right? Next stop is, do they have a pulse or not? And then from there, we're putting it into our tachycardia bucket, or we're putting it into our cardiac arrest bucket. So ventricular fibrillation. So ventricular fibrillation is also a wide QRS complex rhythm because it's coming from the ventricles, but it's not always able to necessarily see that. It's really dependent on the exact ventricular fibrillation rhythm that you have in front of you. So it may not always be as crystal clear as this in terms of, yeah, I got some wide complexes there. It really just depends on what version of VFib you have in front of you as you're sitting there looking at it on the monitor or on the printout. So remember with ventricular fibrillation, when we go back to atrial fibrillation, I said your atrias are just fibrillating, right? Well, in ventricular fibrillation, your ventricles are doing the same exact thing. Now your ventricles are just fibrillating. And when my ventricles are fibrillating, opposed to having that full contraction, relaxation, when I have the fibrillating ventricles, I kind of get this squiggly, chaotic waveform. Okay. Now, from a cardiac arrest perspective, hopefully we can see a ventricular fibrillation or a pulseless VTAC rhythm on the monitor, because those are both rhythms that we can defibrillate. And we're going to talk about that a little bit more in a few minutes. But if the patient is in cardiac arrest, VFib or VTAC is really what we want them to be in, because those rhythms can be defibrillated, which gives the patient the best chance of actually getting back into a normal, organized rhythm that can hopefully sustain life. So this is ventricular fibrillation, or one version of it. Again, you're going to see, just like VTAC, you're going to see a lot of different kind of versions of this, I'll call it. And sometimes VFib is really, really easy to pick out. It's very obvious. You can see it from 30 feet across the room. And other times you really got to look closely and figure out, is this ventricular fibrillation I'm looking at, or is this just asystole with kind of this weird squiggly baseline? What exactly am I looking at? So VFib can be a little tricky to identify, but overall the concept is the same. You're going to have some wide complexes in there that you're able to say, yep, that would be a complex and it's wide. Um, and it's going to be chaotic. There's going to be no regularity to it. You're probably going to have kind of differing amplitudes. And what I mean by that is just different size um, complexes throughout the rhythm. It's just very chaotic to look at. Okay. Now, unlike ventricular tachycardia, VFib cannot have a pulse. VFib never has a pulse. We don't have to necessarily worry about that. Now, if you're in paramedic school and you're actively going through the dynamic and static cardiology stations, your instructor may tell you every time there's a rhythm change, ask if there's a pulse associated with it. That's fine. That's a good habit to be into. But VFib, if a patient is actually in VFib, they are not going to have a pulse associated with it. So now let's talk about asystole. So asystole is an absence of all electrical activity, right? It's flatline. It's the most popular EKG rhythm that pretty much anyone walking down the street probably knows thanks to all these medical shows. But asystole is completely flatline. There is zero electrical activity whatsoever. And usually this is a terminal rhythm. And what do I mean by that? So terminal rhythm meaning this is usually the rhythm that patients are in when we end up pronouncing them in the field or in the hospital or wherever it may be. So there is no other rhythm, there's no other cardiac rhythm for a patient to progress into or transition into at the end of life. Okay. So I mentioned a few minutes ago that VFib and pulseless VTAC is really what we hope to see in a cardiac arrest patient because it kind of gives us the best chance of resuscitation and a little glimmer of hope that we have some more interventions we can do for those patients. Well, asystole is really the opposite of that. When we see that, it can be a little discouraging because we can't do as much for asystole as what we can for VFib and pulseless VTAC. And we know that it's usually a terminal rhythm, meaning that most often the patient either went straight to asystole or he or she has already been through pulseless VTAC or VFib, and that window of opportunity is gone, and now they're in asystole. Okay, so asystole is that flat line, absence of all electrical activity. Remember to check your leads or your pads and make sure they're actually on, make sure they're actually connected to the monitor, because if not, if they don't have a good connection to the patient or they're not actually plugged into the cardiac monitor, it can look like asystole on the monitor, which is why generally from an EMS side, we always try to, if we're going to pronounce a patient in the field, meaning we're going to announce that patient is dead in the field, that we try to document and produce that we saw asystole in 2 or more leads. So that's just kind of extra verification that what I was seeing on the monitor in the very beginning in lead 2 was legit. It was asystole. I also verified that in lead 3 or lead 1 or whatever lead it may have been. So now pulseless electrical activity or PEA. So this one gets a little bit trickier. And the reason for that is, and especially in paramedic school, and I'm not sure where you all are at kind of in your journey throughout this, but PEA gets a little bit tricky, and especially in a paramedic program setting because we are our nerves are already through the roof. We're anxious when it becomes our turn in that static or dynamic cardiology station. The instructor puts one of these rhythms on the screen, and of course, it looks like a normal rhythm or a rhythm that a patient could have life with. So we just automatically assume that it is, right? So pulseless electrical activity is not necessarily a specific rhythm of its own. It can be any rhythm that is pulseless. Um, we exclude VTAC and VFib from that, but anything else, it could look like sinus tach. It could look like a normal sinus rhythm or sinus Brady. It could look like a junctional escape rhythm. It could look like junctional tach. It could look like anything. It just doesn't have a pulse associated with it, which is why it's called pulseless electrical activity. There's electrical activity. I'm sitting here witnessing it on the monitor, but there's no pulse that actually corresponds to what I'm seeing. So As it says here, this is a condition that has an organized electrical rhythm on the monitor, but does not produce a pulse. The patient is pulseless and apneic. So remember, if a patient is pulseless, they're going to be apneic, meaning they're not breathing, or they're going to have agonal breathing, kind of those last few shallow breaths in the last few minutes of their cardiac arrest there. So remember, if they are pulseless, they're not going to be breathing. So now we have a circulation problem. We also have an airway and a breathing problem, which brings up a good point. So generally through EMT and paramedic school, our brains are trained to think ABCs, ABCs, ABCs. Remember, in a cardiac arrest, that switches for us, and we should think CAB. So circulation, airway, breathing. I've got to get compressions going first. I can manage the airway after that, but it doesn't matter if I'm bag valve mask ventilating the patient perfectly and I got the perfect size ET tube in. None of that matters if we're not doing chest compressions and we're not trying to fix the cardiac problem, right? We can breathe for that person all day long. It's never going to bring back their heartbeat, and it's never going to circulate perfused blood around the body to the brain and the kidneys and all these vital organs. So CAB becomes the line of thought at that point in a cardiac arrest situation, because we are focusing on circulation first. Then we are going to worry about our airway once we get CPR going, or we get the Lucas device on, or whatever that looks like in your agency or in your paramedic program. All right. So if you were with us for the last few classes that we've done, this will look familiar to you. If not, then welcome to our way of teaching ACLS. So I know we have a few that are on that are not that were not with us the first 2 weeks. So I'll kind of give a brief explanation. So whenever we teach ACLS, and even when I taught it in the paramedic program, of course, this exact lecture would be a 2 or 3 hour long lecture in the paramedic program, right? And as it should be. And now we kind of get the easy way out on the test prep side, because we can just focus on the nuts and bolts and providing lean information. But even when I would go teach ACLS to doctor's offices or wherever it may be, I always taught it the same way. So the way that was we categorize every single cardiac rhythm into either slow, normal, fast, or dead. Okay. Slow rhythms meaning any bradycardic rhythm. And remember, if we're working under that slow or that bradycardic algorithm, they also have to be symptomatic. My normal rhythms, or my normal bucket, you kind of have to have an open mind with us there. It's not just normal sinus. I guess technically that's probably the only normal rhythm, right? But it's any collection of rhythms that, yeah, we'll see in the back of an ambulance, but we're really not going to do anything for them. So normal sinus, sinus tach, AFib, as long as it's at a decent rate or an okay rate, a flutter, as long as it's at an okay rate, accelerated junctional tachycardia, those types of rhythms that may not be quote unquote normal. But if I hook up a patient in the back of an ambulance and they're in one of those rhythms, as long as they're at an appropriate rate, it doesn't change anything I'm going to do, right? I don't have a protocol for those. So we put those rhythms into our normal bucket. And then our fast rhythms, we focus on that 150 or 160 beats per minute or higher. So our SVT and our VTAC. Okay. And we further break that down. And I'm happy to share that video with you if you haven't seen it. That's no problem at all. So just remind me at the end of this, and I'll gladly provide access to it. So then finally is our dead rhythms. So this is our VTAC, VFib, PEA, and asystole. So with our, and I'm going to write on the screen, so it might bounce around a little bit, so bear with me. So what we are going to do is we're going to start two columns, VTAC and VFib over here, and this is pulseless VTAC. And over here I have asystole, PEA. Okay, so we covered all four of those rhythms tonight. I know it's kind of fast paced, but it's recorded, so you can go back and watch. We covered all four of those rhythms tonight, but we are splitting them off into two different groups because the groups that they're assigned to is dependent upon how we treat them. So pulseless VTAC and VFib, obviously the very first thing we need to do is one, recognize it. Well, we need to start CPR. We need to defibrillate as soon as possible. Again, when we see that pulseless VTAC or VFib, that's our window of opportunity. As soon as I can defibrillate the patient, I am going to move to defibrillate the patient. And then we are going to get into our epi. So our epinephrine, and that's going to be 1 milligram. And remember, that is of the 1 to 10 or 1 to 10,000 concentration. And how often are we given that? We're going to give that every 3 to 5 minutes for the duration of the code. It's not that common that we just give medications without any maximum dose, right? And unless your protocol dictates that, ACLS doesn't dictate a maximum dose of epinephrine in a cardiac arrest. So we're going to give 1 milligram of our 1 to 10 or 1 to 10,000 epinephrine via IV push or IO every 3 to 5 minutes for the duration of the cardiac arrest. So remember, every 2 minutes, we are stopping compressions to analyze the rhythm, check to see if the patient has a pulse. So I'm going to continue down this list as if we are checking every 2 minutes, but the patient never changes, okay? So we are going to defibrillate again after our 2 minutes is up. And what I should have spoke about up here is what we are going to defibrillate at. So if you're using a biphasic monitor, which odds are you are, you can start at 200 joules. And again, or manufacturer's recommendations. There are some differences between Zoll monitors and LifePak 15s, which are probably the two most popular. So make sure you check with your monitor and your protocol and your program. But I'm speaking about a LifePak 15 here. So our first defibrillation could be at 200 joules. We would give our epinephrine after that. Of course, we're doing our 2 minutes of CPR while we give that epi. Our 2 minutes is up. We check a pulse, check a rhythm, still no pulse, still in VFib or pulseless VTAC. We're going to defibrillate again. This time we're going to defibrillate at 300 joules. Now here, you could either do another round of epi or you can go ahead and give your first bolus of amiodarone. And this is going to be a bolus of 300 milligrams. Our 2 minutes is up. We're going to shock at 360 joules. And then for all subsequent defibrillations, we're going to shock at 360 joules. It doesn't go up from there. For LifePak 15, the manufacturer's recommendations are 200, 300, 360. And then we just continue to defibrillate at 360, 360, 360, 360. So I won't repeat that continuing on. So we'll defibrillate at 360. After that, we're right back into CPR again for another 2 minutes. We can do another dose of epinephrine because it should be about 3 to 5 minutes at that point. Defibrillate. I'm running out of room. And again, there's my dosage. And then my second, which I really wanted to get to, my second amiodarone bolus of 150 milligrams. Okay. So any questions on that? CPR right off the bat. We recognize the patient's in cardiac arrest, so we got to start CPR. Okay. Defibrillation happening as soon as we can possibly get it to happen. From there, that kind of kicks off our 2 minute cycles. So we got epinephrine going, 1 milligram of 1 to 10 every 3 to 5 minutes. That's going to happen for the duration of the cardiac arrest. We're going to defibrillate again at 300 joules. I'm going to give my amiodarone 300 milligrams IV push. Defibrillate again at 360 joules, which is where I'm going to stay for the remainder of this event. Go back to my epi again. my 1 milligram every 3 to 5 minutes. And of course, there's other things happening here that I didn't talk about, as far as advanced airway management and waveform end tidal capnography on that endotracheal tube. All of those things are happening. But I'm really focusing on the ACLS algorithm of the steps we do to treat the pulseless VTAC and the ventricular fibrillation. CPR, defib, epi. Defib, amio, defib, epi, defib, amio, right? And we just continue that out. We only give 2 doses of amiodarone in the ACLS protocol, but you can continue giving your epinephrine, that 1 milligram of 1 to 10 every 3 to 5 minutes. And of course, we're also looking at H's and T's throughout this, right? Which I'm going to talk about once I get done discussing asystole and PEA. So remember, those H's and T's are those what could be some underlying factors or some underlying causes of this that we can start to address in the field. They're not necessarily going to fix the cardiac arrest, but if I do get ROSC back, it may put the patient in a more favorable environment and the big picture. But any questions on that before I jump over to asystole PEA? It's fine if there's not. I just don't want to I don't want to move too fast on you. Okay. So now asystole PEA, this one's much simpler. Okay. And somebody taught me this a long time ago, and it's has always stuck in my head, and you may have heard it yourself. PEA, you can remember that as push, epi, always, right? It's just an abbreviation to remember that with asystole or PEA, all we're doing is epi, right? Of course, there's other things happening. There's airway management happening, CPR is happening. But the big thing there is to remember as a paramedic student is, okay, we are not shocking this rhythm. I'm also not giving an antiarrhythmic to this rhythm. I am giving epinephrine, and that is all I'm giving is epinephrine in terms of an actual IV medication. So with asystole and PEA, CPR, again, patients in cardiac arrest, so we need to do that right off the bat. We get them hooked up to the monitor. We realize they're in asystole or they're in an organized rhythm that's pulseless, which would be PEA. There is no defibrillation. So we're at epi, 1 milligram every 3 to 5 minutes, just like we did over here. 2 minutes is up. We're checking the monitor, nothing, right back into the CPR. We can give epi when it's been 3 minutes. Our 2 minutes is up, check the monitor, nothing, right back into CPR. We can do another epi if it's been 3 to 5 minutes. That cycle just continues itself, okay? With, again, there's other things happening simultaneously, and also considering our H's and T's to rule things in or rule things out to hopefully make it a more favorable environment if we are to get ROSC for a patient. So asystole is much easier in terms of the number of steps or the number of interventions we have, but sometimes as a paramedic student, it can be a little bit more difficult because our mind goes to cardiac arrest. I need to shock them. Nope, we don't shock or we don't defibrillate asystole and PEA. That's only for pulseless VTAC and ventricular fibrillation. Any questions on this asystole and PEA lean view here of the ACLS algorithm or pulseless VTAC VFib? Okay. So one thing that I will mention real quick before I talk about H's and T's is for your antiarrhythmics. So your anti-A's there. Bear with me writing on a vertical computer screen. I talked about amio for VFib and pulseless VTAC. 300 milligrams is the first IV bolus dose. If the patient continues to be in VFib or pulseless VTAC, and I get to that point in my algorithm, 150 milligrams IV push is my second bolus. Remember, the only time we give a bolus of amiodarone is in this situation, VFib or pulseless VTAC. For stable VTAC with a pulse, We are given amiodarone. We are given 150 milligrams of it. We're just giving it over 10 minutes of time. We're doing it as an infusion. If we give a beating heart a bolus of amiodarone, there's a really strong chance that that beating heart is no longer going to be just that. It's no longer going to be a beating heart. We're going to put them into a cardiac arrest rhythm. So we want to make sure that we don't do that. But in a cardiac arrest scenario, we give it as a bolus. Now, the other antiarrhythmic that ACLS algorithm recognizes that you can give, if you so choose, is lidocaine. And this is not in addition to amiodarone, it's in place of. And this is 1 to 1.5 milligrams per kilogram with a follow-up dose of 0.5 to 0.75 milligrams per kilogram. So if you don't have amiodarone, you can use lidocaine in its place. I don't know of a ton of agencies doing that just because lidocaine can be a little bit more challenging to actually figure out what the drug math is, because now all of a sudden I'm not just giving 300 milligrams IV push like I am with amio. I'm giving 1 to 1.5 milligrams per kilo. So I'm guessing on a patient's body weight in pounds, most likely. I'm got to convert that to kilos, and then I got to work out this drug math problem to figure out what my lidocaine doses need to be in this situation. So not happening all that routinely, but it's certainly still an option, and it's in the ACLS protocols for this. So just kind of keep that in mind. All right, the last thing, and I mentioned this already, are H's and T's. So remember, under the cardiac arrest algorithm, whether you're asystole PEA or whether you're VFib, pulseless VTAC, the H's and T's are those reversible causes, are items that we need to be considering throughout the cardiac arrest. Now, generally, as paramedic students, we always think of it at the end of the cardiac arrest, right? Because it's like, well, I've done everything I can do for him. What else should I do? Oh, H's and T's. But ideally, this should be going on throughout the cardiac arrest scenario, especially if you have some sort of a higher index of suspicion for one of these in particular. Don't wait until the very end of the cardiac arrest to then try to start correcting it, or then start giving an antidote to an overdose or whatever it may be. Address it when you can. We need to make sure that we're doing CPR and that we're giving epi and that we're defibrillating if they're in a shockable rhythm. We have to make sure those things are going on. But there's some kind of extra time in those 2-minute cycles that we can give a dose of Narcan, or we can give a dose of D50 or D10 or whatever it may be. So even though H's and T's are at the bottom of the protocol or the bottom of the algorithm, don't necessarily think that that's absolutely when they have to happen. That's just often as paramedic students when we start to think about. So with H's and T's, these are going to be our reversible causes, and I'm just going to write out a few here. So hypoxia in a cardiac arrest situation, we should be addressing hypoxia from the very beginning, right? We're bag valve mask ventilating, we get a supraglottic airway in, or we endotracheally intubate the patient. That should be addressed. We also have hydrogen ion acidosis. So the antidote to hypoxia is oxygen. The antidote to hydrogen ion acidosis is sodium bicarb, or HCO3. And a lot of cardiac arrest protocols have 50 milliequivalents of sodium bicarb being given near the end of a cardiac arrest. Excuse me, if it's been some sort of a prolonged downtime. We have hypo or hyperglycemia. We have hypo or hyperthermia. And I feel like I'm missing one more. off the top of my head. I'll come back to it. T's. We have a tension pneumo. How do we fix a tension pneumo? We do a needle decompression. We have tamponade. How do we fix a tamponade? We don't necessarily. Air Medical can do a pericardiocentesis. It's not a definitive fix, but it at least provides some relief. So we have tension pneumo, we have tamponade, we have toxins, which that could be anything toxic. We automatically just think opiates, but really it could be anything that could have put them in that situation. So as we're going through our cardiac arrest scenario, that's really what we need to be thinking about is what put my patient into this. Is it something that can be addressed or reversed? There's a decent chance that it may not be. And also, like I said in the very beginning, keep in mind that this fixing these isn't going to fix the cardiac arrest either. So if a patient's in ventricular fibrillation or if a patient's in pulseless VTAC, just by me giving them bicarb or just by me giving them D10 or just by me giving them Narcan, and that's not going to fix the cardiac arrest. It's too late for that. But what it is going to do is it's going to put them in a little bit more favorable position if they do have ROSC to kind of recover from that. So hypo and hyperkalemia was something that I had originally forgot, and then thrombosis is another one, and that could be a pulmonary thrombosis or pulmonary embolism, or a coronary. Forgive my handwriting here on a computer, or a coronary thrombosis, which would be my myocardial infarction. Okay. So those are some of the H's and T's that we can think about. Those have changed over the years. Some things have been eliminated, and some things have been added too. But those are things that as we progress through our cardiac arrest, we should be thinking of those. We should be thinking of how can we address them. Maybe you can, and maybe you can't. But certainly in paramedic school, you're going to be expected to ramble off a few H's and a few T's, if not the entire list, depending upon your program. So those are definitely something they often get forgotten about, but they shouldn't, not only in paramedic school, but also in the back of the paramedic unit. So that is what I have, which we're about 40 minutes in, and the other ones were 45, 50 minutes in length. So we're doing pretty good on time. We lasted longer than what I expected us to with cardiac arrest rhythms. So any questions for me before we end for tonight? And again, if you do, just put it in the Q&A section of this. While I'm waiting to see if any of those come through, next week, 1 week from today, on Thursday, February 29th, on leap year, we will be doing a basic 12 lead EKG interpretation lecture, and we're not going to charge for that. It is going to be free. We're going to advertise it as free. Some more information to come, but I'll spend about an hour just doing basic 12 lead EKG interpretation, breaking down exactly what are we looking at on a 12 lead, why does it matter, how do we apply it, and what is a STEMI, right, and STEMI identification. So hopefully you can join me next week as we spend about an hour covering 12 lead EKG interpretation. Other than that, I appreciate you jumping on tonight. And again, if you have any questions, feel free to send them my way either now or if you think of them later through our email, and I'll be happy to answer them for you.